Practical Pharmacokinetics, Part 1, Fundamental Concepts.
Hello everyone, and welcome to the Pharmacy Tutor. My name is Ken Eto. Pharmacokinetics sounds like a tough mathematical topic to learn. Many kineticists have attempted to teach it by showing complex equations without providing the proper understanding and reasons as to why they are using them. Kinetics can be easy to learn if you simplify it, take it step by step in an organized, logical presentation, and emphasize what's important and what isn't. This is why I call this series of lectures Practical Pharmacokinetics. The word pharmacokinetics is derived from the Greek words pharmakon, drug, and kinetikos, moving or putting in motion. In parts 1 of 3 of this lecture series, we will cover the fundamental aspects of pharmacokinetics. As you see in the diagram behind me, this includes the traditional kinetic parameters of volume distribution, half-life, KEL, clearance, peak, and trough. We will learn how to dose vancomycin and aminoglycosides using conventional empiric methods. Once drug levels are drawn, we will go over drug level analysis techniques to modify dosages if needed. While pharmacokinetics deals with drug disposition in the body, pharmacodynamics describes what the drug's effect has on the body. It deals more with concepts such as AUC, MIC, and peak concentration killing. As I'll describe in part 4 of this series, pharmacodynamics has formed the basis of a new way of thinking of how to dose vancomycin, and has emphasized the role of using Bayesian modeling and prediction. Since Bayesian theory is new and untested, I'll go over a new and exciting alternative way of dosing vancomycin. But let's start off with the fundamentals in part 1 of Practical Pharmacokinetics.
Here are the topics that we will cover in each of the 5 parts of this lecture series. In Part 1, we'll go over fundamental concepts of kinetics. In Part 2, we'll do some calculation estimates of vancomycin and aminoglycosides. In Part 3, we'll perform drug level analysis. In Part 4, we'll discuss pharmacodynamics and Bayesian application. And on Part 5, we'll wrap it up and talk about clinical monitoring of antibiotics. First, some background information. Basic kinetic concepts, parameters, and equations have not changed over many years. Some institutions have modified their numbers and equations to suit their patient population or studies, but the fundamentals remain intact. Sometimes it's difficult to know which of the many available equations should be used to solve certain clinical kinetic problems. Do I need to memorize multiple equations? I'll try not to overburden you with excessive formulas to use. Only the necessary equations will be presented. While the basic pharmacokinetic concepts have not changed, what has changed recently is how kinetics is applied. In parts 1 to 3 of this series, we'll be talking about pharmacokinetics. Pharmacokinetics is defined as the disposition of the drug in the body, and we use conventional dosing methods to dose vancomycin and aminoglycosides. In part 4 of this series, we're going to switch gears and talk about pharmacodynamics, which is the effect or action of the drug applied on the body. Pharmacodynamics presents a new way of dosing vancomycin and aminoglycosides. Here's a concentration time curve of a drug being administered and eliminated. It shows the basic pharmacokinetic parameters of peak and trough levels, VD, KEL, and area under the curve. Here's the same concentration time curve, but emphasizing different parameters. With pharmacodynamics, we're interested in the peak to MIC ratio, the time above the MIC, and the 24-hour AUC over MIC. So let's begin to talk about pharmacokinetics. Here are the key pharmacokinetic parameters that we will be using. VD, or volume distribution, KEL, which is the elimination rate constant, T1/2, half-life, steady state, C peak, or peak level, C trough, or trough level, tau, or dosing interval, and clearance, CL. Here's an example of a drug administered to a patient. A single dose is distributed into a volume Vd, achieving a certain blood concentration Cp. Cp is a serum concentration of a drug at a specific time. This can be described mathematically using the equation Cp equals dose divided by Vd. This is a fundamental kinetic equation that you need to memorize. The volume of distribution, or Vd, is defined as the volume of fluid into which the total amount of a drug would need to be evenly distributed throughout the body to achieve a concentration equal to that in the plasma. The volume of distribution specifies how widely a drug is distributed within the body, and it represents the volume into which the drug is dissolved. The volume of distribution relates the concentration of drug in the plasma to the amount of drug in the body as follows. We take the fundamental kinetic equation that we just learned and rearrange it to solve for Vd, which is equal to the dose divided by the serum concentration, or Cp. Note that the units of Vd is liters per kilogram. There are differences in the characteristics of drugs depending on the size of their volumes of distribution. Drugs with small VDs are those that are primarily restricted to the intravascular space, are highly water-soluble compounds, and those that are highly protein-bound, whereas those drugs that have large volumes of distribution are drugs that are extensively tissue-bound and are lipophilic drugs that distribute to tissues. Some examples of drugs with small VDs are aminoglycosides 0.26 liter per kilo and daptomycin 0.1 liter per kilo. Drugs that have large volume distributions include vancomycin 0.7 liter per kilo, total body water 0.65 liter per kilo, and amiodarone, which has a very large and wide volume distribution of 60 liters per kilo. When a drug is eliminated, its decline can be profiled as an exponential logarithmic decline, plotted as a concave curve. For calculation purposes, it's easier to visualize drug elimination using the natural log on the y-axis. This provides a straight line depicting drug decline. The slope, or KEL, can be calculated by drawing two levels, then comparing the rise and the run. This can be mathematically described as the log of C naught, or C initial, minus the log of CT, or C after a certain time, divided by the difference between T1 and T2. This is mathematically the same as the equation CT equals C naught e to the minus KT. This is called the degradation equation, and it's a fundamental kinetic equation that you need to memorize. It's a very useful equation that you can use to solve for the final concentration of a drug, CT, when degrading an initial drug concentration, C naught, over a certain time period, T, with an elimination rate constant, KEL. Alternatively, and more importantly, you can solve for any one of the unknown values if the other three are known. Let's try solving for KEL. If you know the other three values, we can solve for the fourth one, KEL. We can take the natural log of both sides, and it's mathematically the same as the equation K equals minus log of CT minus log of C naught divided by T. It's important to remember that the units of KEL will be in terms of the time you use to measure it. So for example, if we're measuring time in hours, then the units of KEL will be in hours minus 1. Question: if it takes 5 hours for a drug level to decline from a level of 9 to 4, what is the KEL? We can use the degradation equation to answer this question. To find the answer, we insert 4 as the concentration after a certain time, 9 as the initial concentration, and 5 hours as the time difference. We take the natural log of both sides and eventually come up with a K of 0.162 hours minus 1 as the answer. Half-life is defined as the time it takes for half of the amount of a drug present in the bloodstream to be removed. So if it takes 6 hours for a drug level to decline from 8 to 4, then the half-life is 6 hours. If you know the KEL of a drug, you can easily calculate its half-life. Just take 0.693 and divide it by the KEL. Remember, the units will be in terms of the time you use for the KEL, that is seconds, minutes, hours, or days. And this is a fundamental kinetic equation that you need to memorize. Question: if the KEL of a drug is 0.162 hours minus 1, what is the half-life? We simply take 0.693 and divide it by the KEL, 0.162, and we get an answer of 4.3 hours. Here are two different methods of drug administration. In constant drug infusion, a certain amount of drug is given as a continuous infusion over a period of time. In multiple dosing of intermittent boluses, a certain amount of drug is given intermittently at different intervals over a course of a time period. In constant drug infusion, you can see that the initial amount of drug going in is greater than the amount going out, so the drug is still accumulating. At a certain point, the amount going in and the amount going out reaches equilibrium, and this is known as steady state. The same holds true for intermittent boluses, where it takes time for the drug to accumulate to reach a point where drug in equals drug out, or steady state is reached. Steady state occurs when the amount in equals the amount out. When multiple doses of a drug are given, it accumulates in the body until the amount administered is equal to the amount eliminated. When this occurs, drug concentrations in the plasma will plateau and will have reached steady state. Steady state is when the rate of drug intake matches drug output, and there is no further accumulation of drug. Even though more doses are given, a consistent amount of drug remains in the bloodstream and levels stay constant. It takes time to reach steady state. Steady state is typically reached after 4 to 5 half-lives are achieved. This is an important concept to remember. Why is steady state so important? It's important since doing peak and trough levels too early before steady state is reached will give inaccurate results. You can see in the diagram the peak and trough levels that are drawn around dose number 3 are not drawn at steady state and are inaccurate. You must draw drug levels at steady state to ensure consistent and accurate results. Another way to think about steady state is to look at degradation and accumulation. It takes 4 half-lives for a drug concentration to go from 16 to 8 to 4 to 2 down to 1. After 4 half-lives is reached, 94% of the drug is gone, so it's essentially near fully degraded. Here's a table that illustrates this. Likewise, when we think about accumulation, it takes 4 half-lives for a drug concentration to go from 1 to 2 to 4 to 8 to 16. After 4 half-lives is reached, 94% of the drug has accumulated, so it's very close to steady state. Here's a table that illustrates this fact. When multiple doses are given and levels are at steady state, we can estimate the peak level. We must not only account for the dose given to achieve the peak level, but also must include the fraction lost in the dosing interval. This fraction is represented by 1 divided by 1 minus e to the minus k tau. When the two are combined, this then becomes the equation to solve for the peak level at steady state. C peak equals dose divided by Vd times 1 minus e to the minus k tau. This is a fundamental kinetic equation that you'll need to memorize. We can now solve for the trough level at steady state. We must first move the trough over, which is legal to do since we are at steady state. Then we apply a form of the fundamental degradation equation. So to solve for the trough, we must take the peak level and multiply it by e to the minus k tau. This is a fundamental kinetic equation that needs to be memorized. There are additional equations to use called the long equations. These equations are to be used when the drug's half-life is short and you need to account for drug elimination during the infusion period. They are longer, modified steady-state peak and trough equations that you'll need to be familiar with and be able to look up when needed. When do you need to use the long equations? Only when the half-life of the drug is very short. So for aminoglycosides, use the long equations when the half-life is less than 3 hours, and for vancomycin, a half-life of less than 6 hours. Clearance is defined as the volume of blood in mLs or liters from which a drug is completely removed per unit of time in minutes or hours. Usually, clearance is measured in liters per hour or mLs per minute. Clearance does not tell us the amount of drug cleared. Total body clearance is the sum of all processes by which the drugs are removed, primarily renal excretion and non-renal clearance, liver metabolism, biliary excretion, etc. Because clearance is removal of drug from the circulation, clearance is related to the elimination rate constant and the apparent volume into which the drug is dissolved. It can be expressed mathematically as clearance equals KEL times VD. This is an important fundamental kinetic equation that you'll need to memorize. The following two tables provides a review of the pharmacokinetic parameters that we have just discussed. It provides their definitions as well as how they're mathematically expressed. Now let's take a moment and talk about creatinine clearance. Is there an easy way that we as clinicians can mathematically calculate how good a patient's renal function is on a daily basis? Yes, there is. In 1976, Cockcroft-Gault derived their unique equation, which even today is considered the gold standard in estimating a patient's creatinine clearance. Their formula is based on using a patient's age, weight, and serum creatinine levels to closely predict a patient's renal function. This simple equation can be very useful in assessing the clearance of renally excreted drugs and to make necessary dosage adjustments if needed. Let's first talk a little bit about the serum creatinine. Serum creatinine is a lab value that's used to monitor a patient's renal function. The serum creatinine is a byproduct of muscle metabolism. It's eliminated primarily by the kidneys, and it will accumulate in renal insufficiency. The normal value is 0.6 to 1.2 milligram per deciliter. And here it is, the Cockcroft-Gault equation. Creatinine clearance expressed as mLs per minute is equal to 140 minus age divided by the serum creatinine times the weight in kilograms divided by 72 times 0.85 if the patient is female. This is a fundamental equation that you'll need to memorize. Some important rules to remember is that we need to use the appropriate weight, either ideal body weight, actual body weight, or adjusted body weight. So we'll take a look at that in a minute. We also need to round the serum creatinine up to 0.8 if its value is less than 0.8, and use 1.0 as a serum creatinine if it's warranted. And we'll also talk about this in a minute. If the patient is female, we need to multiply the creatinine clearance by a factor of 0.85, as I mentioned previously. So which weight do I use to calculate creatinine clearance? You'll need to take 3 steps in order to answer this question. Step 1, we need to calculate the body mass index, or BMI, which is equal to the weight in kilograms divided by the height in meters squared. Remember that 0.0254 meters equals 1 inch, so you can use this as a conversion factor. Step 2 is to calculate the ideal body weight. For males, we take 2.3 times the number of inches greater than 5 feet in height, and we add it to 50 kilograms. For females, we do the same thing, but we add it to 45 kilograms instead of 50. Step 3 is to then find the appropriate weight to use based on the table. If the patient's actual body weight is less than the ideal body weight, use the actual body weight. So these are smaller patients that are less than their ideal body weight. If the patient's actual body weight is greater than the ideal body weight, then we use the ideal body weight. If the patient's body mass index is greater than 30, which is considered obese, we would use an adjusted body weight, which is equal to the ideal body weight plus 40% or 0.4 times the actual body weight minus the ideal body weight. This is to add on to the ideal body weight a certain amount of vasculature that can occur in the obese tissue. Which serum creatinine do I use if it's less than 0.8? If the serum creatinine is less than 0.8, you want to round upward and use 0.8 in your creatinine clearance calculation. However, in certain cases, rounding the serum creatinine to 1 instead of 0.8 may lead to a more accurate estimate of creatinine clearance and be more appropriate. For example, in severely underweight or emaciated patients, since the serum creatinine is a byproduct of muscle metabolism, emaciated patients will have a decreased muscle mass and thus a lower production of creatinine. The patient's low serum creatinine value may not truly reflect their renal function and can lead to an overestimation of creatinine clearance. Another example would be patients with spinal cord injury. They'll have a significant loss of muscle mass and thus will have a lower than usual serum creatinine value. Another example will be in hemodynamically unstable patients, where you anticipate a sudden decrease in renal perfusion resulting in a worsening of renal function. In these cases, you may want to use serum creatinine of 1 instead of 0.8 and round up to 1. Here are some interesting facts about the Cockcroft-Gault equation you might have not known about. The study was performed at a veterans hospital in Montreal, Quebec. Of the patient demographics, 96% of patients were male. The patients were primarily on medical wards, not in ICUs. The age range was 18 to 92 years old. The average weight of patients was 72 kilograms. And the mean serum creatinine in the 7 age groups ranged from 0.99 to 1.39 milligram per 100 ml. Some other interesting facts about the Cockcroft-Gault study included 2 or more collections of 24-hour urine were used to determine the clearance of creatinine. The measured creatinine clearance ranged from 37 to 115. The maximum creatinine clearance should be capped at 130 ml per minute. The authors note in their discussion, although we have not corrected for excess fat or fluid because of inadequate data, a correction to lean or ideal body weight is advised when these abnormalities are pronounced. Here's a summary of what we discussed in Part 1. We outlined fundamental pharmacokinetic parameters such as VD, KEL, half-life, and peak and trough. We discussed the concept of steady state and the importance of achieving it when drawing levels. We listed essential kinetic equations that require memorization. And we described how to calculate creatinine clearance using the Cockcroft-Gault equation. In Part 2 of this series on practical pharmacokinetics, we will learn how to calculate empiric doses of vancomycin and aminoglycosides using traditional kinetic equations. So stay tuned. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.